All right, let's get right into it. Today we're unpacking a truly fascinating and honestly kind of terrifying clinical paradox. When we're dealing with hydrocephalus or shunt malfunctions, we see ocular motility issues all the time. Problems with eye movement? Super common. But actual permanent blindness? That is incredibly rare. But here's the thing. When it does happen, it's an absolutely devastating complication. So in this explainer, we're going to walk step by step through the exact clinical pathway of how this rare event actually unfolds.
Here is our roadmap for today. We'll cover 1. The rare complication itself. 2. Visual disturbances. 3. Occipital lobe infarction. 4. Pregeniculate pathophysiology. 5. Presentation challenges. And finally, 6. Prognosis. Let's jump in.
Section 1. The rare complication. Let's establish some baseline facts. Now, when we look at the mechanics, there are 3 primary culprits that cause this kind of blindness. First up is the occlusion of the posterior cerebral arteries, or PCA, which is usually triggered by a downward transtentorial herniation. Second, we have chronic papilledema, and that causes direct physical injury to the optic nerve right at the optic disc. And third, severe dilatation of the third ventricle. When that ventricle balloons up, it literally physically compresses the optic chiasm.
Because this complication is so exceptionally rare, finding large data sets is pretty tough, but there's a specific number you need to keep in mind, and that's 34. One really notable study managed to identify exactly 34 reported cases of permanent blindness in children that were directly linked to a shunt malfunction, with that accompanying spike in intracranial pressure.
To really wrap our heads around the severity of this, let's break down some statistics from another major series. This one looked at 100 patients with tentorial herniation. Most of these were from acute epidural or subdural hematomas. Out of those initial 100 patients, 48 went to surgery. Of those, only 19 survived longer than a month. And here's the kicker. Out of the original 100, 9 developed an occipital lobe infarct. For those 9 patients, the outcomes were incredibly grim. 2 passed away, 3 were left in a vegetative state, and 4 suffered moderate to severe disability. It's just a brutal cascade.
Moving on to Section 2, visual disturbances. Specifically, we're looking at the divide between anterior and cortical pathways.
Based on a detailed 14-patient study, we can see a very clear split here. Pregeniculate, or anterior blindness, made up the majority, 9 out of the 14 cases. You can spot this clinically by early marked optic nerve atrophy and reduced pupillary light reflexes. On the flip side, post-geniculate or cortical blindness, which was seen in the other 5 cases, acts completely differently. Surprisingly, these patients maintain normal light responses and show minimal early atrophy. It's like the hardware of the eye works perfectly, but the brain's software isn't processing the feed.
And when we talk about cortical blindness, we absolutely have to mention Anton syndrome. It is such a fascinating yet completely tragic neurological condition. This is where a cortically blind patient actively, genuinely denies that they've lost their vision. Because the visual cortex itself is damaged, the brain literally fails to process the fact that there's a deficit at all.
Another wild and highly specific condition tied to these cortical injuries is redox phenomenon. Picture this. Patients in this state are completely blind to anything stationary. But if an object is moving, they can suddenly perceive it. It's a really stark reminder of just how incredibly complex and segmented our visual processing system actually is.
All right, Section 3, let's dive deep into occipital lobe infarction, or OLI, and look at the exact mechanistic pathways.
The crucial thing to understand here is how this infarction actually happens mechanically. It's a devastating domino effect. First, the rising pressure forces the brain to herniate downward right through the tentorial notch. Second, because the posterior cerebral artery, or its branches, are resting right there on the hippocampal gyrus, they get violently compressed against the free edge of the tentorium. And third, that physical pinching simply shuts off the blood supply, which results in the infarction.
But it's not always a downward movement, right? Upward cerebellar herniation can do this too. For example, if you do a ventricular puncture when there's a mass in the posterior fossa, that upward shift can impinge the PCA with the exact same disastrous results. Plus, a rapid spike in intracranial pressure is uniquely dangerous. Why? Because it just happens too fast. It doesn't give the brain any time to make compensatory shifts, and it completely blocks any life-saving collateral circulation from developing.
Now, there is a tiny silver lining in some of these OLI cases, and it's called macular sparing.
This actually happens pretty frequently, and the reason is that the occipital poles often have this built-in backup, a potential dual blood supply coming from both the PCA and the middle cerebral artery, or MCA. Alternatively, you might just get lucky, and a distinct branch of the PCA manages to dodge that mechanical compression we just talked about, which spares the patient's central vision.
So what else triggers early eye besides the shunt malfunction? Well, the medical literature points to things like post-traumatic edema, tumors, abscesses, subdural hematomas, and unshunted hydrocephalus. It's also super important to note that the occipital poles are uniquely vulnerable to diffuse hypoxia. That's exactly why we sometimes see cortical blindness happen right after a patient suffers cardiac arrest.
We also need to draw a really critical distinction when it comes to trauma. Yes, both coup and contra-coup trauma can cause OLI, but unlike the PCA occlusion we were just discussing, you generally shouldn't expect to see macular sparing in traumatic occipital lobe injuries. Oh, and if you throw hypotension into the mix on top of an already struggling PCA circulation, the risk of postgeniculate blindness shoots way up.
Okay, moving to Section 4, Pregeniculate Pathophysiology. Let's trace that anterior chain reaction.
Let's walk through this anterior pathway step by step. Step 1. We start with elevated ICP. Step 2. That intense pressure is transmitted directly down the optic nerve sheath straight to the retina. Step 3. This physical pressure causes stasis, or a complete standstill, in blood flow. Step 4, at the same time, if that third ventricle is ballooning outward, it's causing direct, mechanical trauma right on the optic chiasm. If nobody intervenes to stop this chain reaction, it's a straight shot to complete visual loss.
And here is a massive clinical red flag to watch out for. If your patient is dealing with hypotension and anemia at the same time, you absolutely must consider ischemic optic neuropathy. This can hit either the anterior or posterior regions, but you really want to avoid the posterior variant, because unfortunately it carries a significantly poorer prognosis.
Section 5. Presentation Challenges. Let's talk about the harsh reality of trying to identify these deficits in a real-world setting.
So, this brings up a huge question. We're talking about profound deficits here, right? Permanent blindness. So why in the world are these so frequently completely missed or unsuspected by clinicians when they first happen?
Well, the answer really boils down to two things: the patient's severely altered mental state, combined with the fact that a lot of hydrocephalus patients are extremely young. It makes detection incredibly difficult. I mean, think about it. A clinician has to have absolute stubborn perseverance to spot subtle signs like homonymous hemianopsias in a patient who is obtunded, barely conscious, or just totally uncooperative. It's a diagnostic nightmare.
And check out how this connects back to our earlier anterior versus cortical divide. Pregeniculate blindness is actually less often associated with a severely depressed sensorium, but postgeniculate cortical blindness is much more likely to show up with a depressed mental state. Which makes perfect anatomical sense, doesn't it? The intense mechanical forces that are causing that cortical blindness are also way more likely to cause direct physical compression and choke off the vascular supply to the midbrain at the exact same time.
Finally, Section 6, Prognosis and Recovery. Where do patients go from here?
The hard truth is, recovery is a painfully slow process. Now, cortical blindness following diffuse anoxia does frequently improve, sometimes even returning to normal, but we are talking about a timeline of weeks to years. Younger patients definitely tend to fare better. However, the sobering reality here is that extensive calcarine infarcts are in all likelihood a permanent end of vision. There's just no coming back from that. Which leaves us with a pretty stark question to end on. Knowing how subtle this presentation can be in an unresponsive patient, and how devastatingly permanent an extensive infarct is, how can we drastically improve our clinical vigilance to catch this before the damage is permanent? Definitely something to think about.